I'm Allison Lipscomb, and as John said, I'm now the North Carolina Community Health Center Association. But I included this slide because when I started, this is where I was. I was doing Farmworker outreach in Boone, North Carolina. I am not from a rural community. I stayed there for 10 years. And I have been doing the same job for 8 years, and I loved it. I did community outreach in the Farmworker camps. I started out at the Office of Rural Health with Elizabeth Freeman Lombard's program, the North Carolina Farmworker Health Program. And when this opportunity came up, I was looking for a new challenge in my job, not knowing that many new challenges were about to come along the way. But the project I really had wanted to do from the start was to deepen a project I had been trying out and piloting the farmworker camps, which was around behavioral health interventions. The farmworkers were very isolated, had a lot of stressors in their lives, and there was not a lot of models out there. So this picture was from a music therapy intervention we had piloted prior to that. So with this project, I was going to formalize that research, do more of an evaluation, create something more sustainable. And then, lo and behold, in June 2012, we got notification that our Department of Community Outreach at the hospital had applied to become a spinoff from the hospital and become a separate migrant and community health center. And we submitted that in 2010. We got funded in June of 2012. So suddenly my life changed dramatically, and I was invited to become COO of that organization. And I have to say, to our credit, the organization had a lot of vision, a lot of mission. We didn't have a lot of experience, and didn't know really what was in for us. So at that point, John was very flexible in allowing me to change the shift the focus of my project to something that would benefit the community health centers we got off the ground. I wasn't doing direct work with farm workers at that point, and so we decided to change the behavioral health focus to piloting behavioral health integration in a new and fledgling community health center. And then, after a year of being in that position, I changed positions and went back into farmworker health, where my true passion is, and came to the Community Health Center Association, where I'm the Special Populations and Community Development Coordinator. So I think we talked about this already. I did maintain some of the original project components in the sense that I wanted to still partner with the graduate programs at Appalachian State University. There's a lot of strong programs in community counseling, music therapy, social work, marriage and family therapy, so I thought that would be a great resource to bring into a small community. And at that point, I also wanted to share the lessons we learned in this project to other organizations in our state. And then my mentor was actually a private marriage and family therapist and professor at ASU, Joan Zimmerman, and was very supportive of the project. So I'm hesitant to even define behavioral health integration. It seems kind of like a moving target, and I also know that Maggie and Peter here have a lot more experience in this area than I do. This was a humbling experience for me because I was coming from it as an administrative perspective. I didn't have, my background's public health and immigrant health, furthermore, so I didn't have direct experience in behavioral health. But it was still a very worthwhile project all the same. But as many of you all know, this can be in a primary care setting, it can happen in a behavioral health setting, but the idea is to bring the whole person together, the head and the body, and it can be different levels of integration as well, from a referral to a warm handoff to total system integration. And one of the experiences I really gained the most from was visiting Rural Health Group, which I believe the presenter earlier featured. It's one of our stronger community health centers in the state. They're in a very rural location in northeastern North Carolina. And I really feel like they've been leaders in behavioral health integration. Dr. Jan Freeman is the behavioral health coordinator there, and then Brian Harris is their CEO. So they invited us to come and see how they do it at Rural Health Group. And there it's a very integrated model. Behavioral health is part of their leadership team, it's part of their mission. Every patient who comes in the door sees behavioral health and primary care. They schedule appointments at the same time. It's one $5 fee for everything. They share the record, and they actually don't say the provider versus behavioral health. Everybody is a provider. They're just part of a provider team. So that was really helpful to see how they did it there and to know that that is kind of ultimately what we're going for. So I actually took this from the North Carolina Foundation for Advanced Healthcare Programs, iCare's website. There's a lot of leadership in North Carolina right now with behavioral health integration through CCNC and through iCare. Kate B. Reynolds is funding some of these projects. And We know there's a huge need for behavioral health. Again, this is excerpted from the website of iCare. So it says not nearly 1/3 of Americans report suffering from some mental or emotional problem each month. We also have data that shows that 70% of primary care appointments have some sort of mental health component to them. Additionally, when we did our needs assessment for the Community Health Center in Boone, in Avery County, we found that suicide rates there were about 3 times the state average. And part of the reasoning that is perhaps the Appalachian culture. There's a huge amount of pride, a feeling of failure in a sort of spiritual way if you have depression or mental health problems, and a reluctance to seek behavioral health care. So I also learned that the history of behavioral health, that system evolved totally, completely, separately, differently from the medical and physical health system. And now it's really hard to bring them back together. And I saw in practice, a lot of the primary care physicians are not trained in handling behavioral health problems, but that's where patients will go first for that kind of care and support. So, that's what I did. So first of all, I want to learn more about behavioral health integration. I visited a rural health group, like I said. I also went to 2 other sites to get a kind of perspective of different models, and went to another community health center in Asheville, Western North Carolina Community Health Services, and then Mountain AHAT in Asheville as well. I also got to go to the Integrated Care Training Academy, sponsored by Cherry Community Health Systems. They were a large behavioral health center that actually brought in physical, medical care later, and is a huge FQHC in Knoxville, Tennessee, and that surrounding area. Finally, I participated in the quarterly behavioral health work group meetings that are organized by my current organization. Then I talked to community partners, and early on, just to give you some perspective, I know the North Carolina behavioral health system has a huge amount of history of challenges, but locally, there are some specific challenges. We had New River Behavioral Health, which in 2011 was defunded and investigated for Medicaid fraud, and that was our system for the low-income uninsured in our area. So Daymark came in, they're a provider throughout the state, I believe, and there was a lot of staff turnover at that time. They had high caseloads, a loss of trust with patients, and also their model was all group therapy. So that was the only option for patients who were uninsured. We also had, because of the conversion to MCOs, managed care organizations, private providers could previously bill directly Medicaid for providing behavioral health services, but lost that capability and then had to go through the MCO, which required credentialing. They got lower reimbursement. It created a lot of burdens for them, so a lot of them decided not to do accept Medicaid anymore in our area. And it was interesting because one provider actually came to us and asked us to bill for him because FQHCs can work around that. And he was the only provider in our area who had been doing integrated behavioral health with a pediatric practice. So we considered that proposal and realized that it wasn't a good fit for us. We didn't really see many kids. So it was a learning process to learn where was the fit for our organization with what was out there in the community. Like I mentioned, I approached marriage and family therapy. The issue with that program was they wanted reimbursement for supervision for their interns, and also wanted to do more in-depth sort of therapy with the patients rather than short brief interventions. Community counseling was going through some sort of change in their departmental leadership, so there wasn't a response there. The social work was the ticket for us. We had great success with that program, and I'll talk about it. So, while we transitioned to this new organization, we met with the department head of social work, and they were seeking internships for their students. And we opened our doors in January 2013, and at that same time, we hosted our first bachelor's in social work student. And then in the fall, we hosted 2 master's in social work students. And I'm going to talk more about their projects in a bit as well. Another part of the methodology was bringing our leadership on board with this, because I had a real passion for this and really believed in this model, but the rest of the leadership team was not familiar with behavioral health. In fact, they were from the mountains and kind of had a sort of stigma around behavioral health as well, like why would we do this? I had a sense that it was kind of just for crazy people, so it was really eye-opening for them to go to the rural health group meeting as well and learn how pervasive these problems are. And then I also assigned 2 of our interns to do presentations to our staff and providers on motivational interviewing and behavioral health. And I have to say, I didn't mention this earlier, but our providers were already coming very soon to us, frustrated and burnt out with the amount of patients coming to them with such complex needs. A lot of the patients hadn't had medical care or behavioral health care for a long time, so they had chronic, complicated health issues. Our providers were getting pulled into doing case management. At the same time, they were getting kind of rushed to be productive and be efficient. So I think there was a real need early on to bring in some sort of support with case management and behavioral health. So they were very receptive to these ideas in the end. So what we ran into early on as well was funding. We, as a new organization, as a new community health center, you do get a grant, and you think it's a lot of money, but it doesn't go that far in the end, especially when you have a huge uninsured caseload. We had 85% of our patients were uninsured. And a lot of community health centers, I think the average is maybe 30 to 40% because you need those privately insured patients and the Medicaid and Medicare to offset the costs of your uninsured patients. So I have to say, by the time I left High Country Community Health, the organization was really struggling financially. So I think they're doing a little bit better now, but it's very bumpy in the beginning. And so at the point I talked to the CEO, she said, you know, I'm on board with this. I want to do behavioral health. However, it has to be self-sustaining. That's the only way we're going to do it.
Hello.
So we realized that there were ways to make it sustainable through billing. However, we didn't have that sophistication early on. So we would need that sort of technical assistance to move forward with it, but also would need some sort of initial funding to kind of jumpstart it and hire an LCSW, a licensed clinical social worker, to bring them on staff. So Peter actually told me to contact KB Reynolds, that they were still funding behavioral health integration. So we contacted Avena and hosted her on site in the fall, and she was really encouraging, really excited about the project. And I want to tell you about the outcome of that in a minute too, in my outcomes section. So what happened? I think this is a huge one. It's now on the agenda of our organization, a new community health center by the time I left. The interns continue taking the work forward that I had started for them with the social work interns, and it's now part of the strategic plan of the organization and a very high priority for it. So the follow-up to the KB Reynolds funding was that we found out later that you had to have something in place already to get funding. So they didn't really want to fund brand new projects, so I'm going to call this later, about a month later, and say, I'm really sorry, this project wouldn't be eligible for funding. So we weren't able to find, at that point, funding to support a brand new project. However, after I left in March, the Bureau of Primary Health Care released a funding opportunity. And I've heard that it's been a very popular funding opportunity. I think they're going to fund 1/3 of the applications submitted. So I really think for me, one of the most rewarding things was working with the social work interns and mentoring them and really learning about the potential with that field in a clinical setting. The social work interns we had, the first bachelor's the social work student we had in the spring of last year, he did some case management. He had a small load of patients. We kind of learned early on some of the challenges with the providers feeling comfortable referring to him, and kind of worked on our workflows with that. And I have to say, they bring the students there, they have to do the internship 32 hours a week, so it's very intensive. And then the master's students we had in the fall, that's actually a year long, and they come 2 days a week. And I think we got the most talented master's students out there. In fact, one of them gave the commencement speech to her class and won a state award. So we really had super talented, motivated students. The one I'm talking about her focus was clinical. So by the time I left, she had really put into place some procedures to do screening with all patients as they came in the door, which knowing to integrate something into a workflow is very difficult, and she did it. So I'm proud of her for that. And then they actually took forward, and once I left, and did the application for funding, which was doing a federal grant application when you're a graduate student. was an awesome undertaking, and they did a great job. So I'm really glad that they also oversaw the bachelor student that came through in the fall, and that bachelor student took on the case management role that was more appropriate for a bachelor's level, and then they got the experience to supervise that person. And they also recruited a student for next fall, so I feel like this is a kind of a sustainable relationship. And something that really helped with that was flexibility of supervision. We didn't have a social worker on staff, but we were co-located in the health department, and they had a social worker that was able to do some of the supervision, and they were able to get supervision from their faculty back on campus. So then I transitioned, like I said, to a technical assistance role with the association in February. And I was hoping to share the results of this project with other community health centers, but one of the humbling things during this course of this project was to learn how much was already going on in the state. And so I did share our final report for this project with Sharon Brown Singleton. She is the leader of the NCCHCA behavioral health work group, and she said, your recommendations are spot on in terms of funding and support needed, but there's not really a lot here that other organizations are going to learn from, which is unfortunately was a little humbling. But it was also exciting to be part of something that a bigger movement that's already going on. So before that, coming forward. When I changed jobs in January, it was a good opportunity to see what would happen when I left the organization, because I was concerned that with all the other challenges going on, that this project wouldn't move forward, that it wouldn't maintain a priority without someone really advocating for it. But it made it into the strategic plan. They applied for funding. They continued doing presentations to the board. So I feel like that showed some success with sustainability. The internships continued. I think to bring the project forward at the organization I left would require a strong internship component still, technical assistance around billing, and some more startup funding as mentioned earlier. So I think one of the biggest things I learned in this project was I feel like we're hearing so much about these new trends with behavioral health integration, PCMH, accountable care organizations, and these are great, but I feel like they are much more achievable at the larger organizations and community health centers that have been around for a long time, such as Piedmont, such as Rural Health Group. It's a little bit shakier to put into place at a new organization, even though they're just as important. So I feel like more technical assistance is needed. Sometimes more grant funding is needed for those organizations to help bring them up to speed. Like I said, we needed technical assistance to help us with the sustainability of bringing behavioral health on board, partnership with graduate programs. It was ended up having great feedback from the graduate students who said, I really do want to practice in a medical setting now, and this was an awesome opportunity for them. So like I said, it was rewarding for me, but also for all our staff and providers at High Country Community Health to see the role that social work can play in the organization. And I think we also involved them in our PCMH application process. And so I think they proved to be a positive example for our providers there. Like I said, the students had strong feedback that this was a great experience for them to be involved with. Like I said earlier, we're going to need more support for new and smaller community health centers to integrate some of these new initiatives at such a fast pace. And experiencing was humbling but rewarding. When I first started out, I was hoping to do a smaller project that was innovative and unique and a small field of farmworker health, and it got much bigger. But it was also rewarding to be part of a bigger movement going on with behavioral health integration, to have that response to and report out from a small community.